Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning. I've reviewed your medical records before our session today. How are you feeling right now?
Morning, doctor. Not great, honestly. The numbness in my hands gets worse, especially at night or when I'm driving, and these muscle spasms aren't helping either.
I see. Let's talk about the numbness first. You mentioned it worsens at night and while driving. Could you describe that in a bit more detail?
Sure. When I'm lying down, it feels like my hands just start to go numb, and I have to shake them out to get some feeling back. Same when I'm driving for more than a half hour. I've been using these wristlets that seem to help a bit with the pressure.
And the muscle spasms, you had a severe episode recently?
Yeah, about 2 months ago it was so bad I couldn't even swallow properly. I ended up in the ER. They gave me a shot of something to calm it down. It's scary when that happens.
Understandably. And I see you've been on cyclobenzaprine for the spasms. Has that been effective?
It helps to some extent, but on really bad days, it feels like it barely touches the pain.
Got it. And how about your diabetes management? Any recent episodes of low blood sugar?
Yes, actually. Last week, I had a couple of days where my sugar dropped to the 30s. I've been trying to manage it by eating regularly, but sometimes I just forget with everything going on.
That's concerning. We need to ensure you're managing your meals to prevent these drops. How have your blood sugar levels been overall?
Generally, it's been all right, but those drops are what worry me. My last HbA1c was 7.2%, so it's not too bad, but not where I want it.
Understood. Let's also talk about your neck pain. You mentioned increasing discomfort.
Yes, the pain has been getting worse. Some days it's just a dull ache, but other times it gets sharp, especially if I've been sitting for a long time. My last MRI didn't show any changes, but it's definitely not getting any better.
I see. And you've been consulting with a neck surgeon?
I had a consultation last month. He suggested we might consider another surgery if things don't improve, but I'm really trying to avoid going down that route again, if possible.
Absolutely. Surgery is always the last resort. Have you been able to engage in physical activities?
I try to, but it's hard. I can manage some light exercises, but anything more strenuous than a walk around the block is too much.
And how has this affected your daily life, in terms of work and personal activities?
It's tough. I'm on disability currently because of my condition. Even basic things around the house can become challenging on bad days. And it's not just physically, it's mentally draining as well.
I can imagine. It's important to address these issues comprehensively. Let's discuss the current plan and any adjustments we might need to make. First, we'll monitor your blood sugar more closely and adjust your diabetes medication if necessary.
Sounds good. What about the pain management?
For the pain, I think we should consider adding a low-dose antidepressant that can help with neuropathic pain. It's often used in cases like yours where the pain is persistent.
I'm open to trying that if you think it will help.
All right, we'll start on that and see how you respond. I also want to schedule another follow-up in 3 months to reassess. Meanwhile, it's crucial to keep up with your physical therapy exercises as much as possible.
Will do. Thanks for helping me sort through all this.
Of course, we'll keep adjusting as needed. Your well-being is our priority, and we'll continue to work together to manage these symptoms effectively.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, since my last visit, I've continued to lose weight, and now I'm down by about 20 pounds since we started the MOVE program. It hasn't been easy, but I've been managing my portion sizes more carefully and avoiding eating out. However, I've noticed more frequent gout attacks, and even though I'm on colchicine, the pain can be quite unbearable at times.
I see you've made significant progress with your weight, which is excellent. However, I'm concerned about your frequent gout attacks. Can you tell me more about these episodes? How often do they occur, and how long do they last?
Well, the attacks have been happening more often, almost once a month now. Each episode can last for several days. The pain usually starts in my big toe, and sometimes it's so severe that I can barely walk. We've had to drain my knee twice because of fluid buildup related to high uric acid levels.
That sounds quite challenging. We'll need to keep monitoring your uric acid levels closely. Have you noticed any specific triggers that might be causing these flare-ups?
I've tried to figure out if anything specific triggers the attacks, but nothing stands out except maybe stress. I've been attending physical therapy regularly and seeing a pain specialist, but managing the pain during flare-ups is tough.
It's good to hear that you are engaged with physical therapy and consulting with a pain specialist. Now, how about your cholesterol management? I see you're on simvastatin. Have you noticed any changes or side effects from the medication?
The simvastatin seems to help a bit with the cholesterol, but I'm still struggling to get my HDL up. That's why I started taking niacin, hoping it might boost my HDL levels. No major side effects, thankfully.
Boosting your HDL is definitely a step in the right direction. You're also on lisinopril and hydrochlorothiazide for your blood pressure. How have you been feeling in terms of your blood pressure?
My blood pressure has been fairly stable, generally around 130/85 mmHg, as you noted today. I don't feel any discomfort there. It's more the knee pain and the gout that bother me.
Understood. And regarding your knee, the x-rays show degenerative changes consistent with osteoarthritis. Have the treatments you're undergoing helped with the symptoms?
The treatments help somewhat, but on days when the pain flares up, it can get pretty bad. The physical therapy helps keep things manageable, but I'm worried about the long-term effects and whether I'll need more surgeries.
I understand your concerns, especially with the challenges you faced. Let's also discuss your vitamin D levels and diabetes management. Are you still taking your vitamin D supplements as prescribed?
Yes, I take the 2000 IU daily and the 50,000 IU weekly, but I'm not sure how well that's working, considering I'm indoors most of the time.
Maintaining adequate vitamin D levels is important, especially for your bone health, given your other conditions. Now about your diabetes risk. Your last hemoglobin A1C was at 6.3%, which indicates that we need to monitor your glucose levels more closely. Have you made any specific dietary changes to address this?
I've been trying to cut back on sugars and carbs, especially after seeing the A1C levels. It's not easy, but I'm aware of how important it is.
It's good to hear you're taking proactive steps. Let's summarize and plan for your care going forward. Firstly, we need to continue monitoring your gout and adjust your colchicine dosage if needed. We'll also keep an eye on your uric acid levels. For your cholesterol, the ongoing use of simvastatin and niacin is appropriate, and we'll check your lipid profile in the upcoming labs. Your blood pressure medications will remain as they are since they seem to be working well for you. Regarding diabetes management, the creeping up of your A1C is concerning, so we'll plan for fasting glucose monitoring and potentially adjust your diet further with the help of a dietitian. For your knee pain, continuous physical therapy and pain management consultations are crucial. We'll also reassess the need for any surgical interventions based on your symptoms and therapy outcomes.
Thank you, doctor. It's a lot to manage, but I'm glad we have a plan. I'll keep up with the treatments and adjustments and look forward to seeing some improvements by our next appointment.
Absolutely. And remember, I'm here to support you through this. Let's make sure you have a follow-up appointment in 3 months.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
I see that you're still experiencing symptoms, even after cutting out bread and pasta. It's important to consider that gluten can also be hidden in less obvious foods and products.
I thought I was doing everything right. What are some other sources I might be missing?
Gluten can be found in products like soy sauce, salad dressings, and even some types of beer. Also, watch out for cross-contamination in kitchens where gluten-containing products are also handled.
That's quite a lot to watch out for. What about non-food items?
You'd be surprised, but gluten is also present in some cosmetics, toothpaste, and medications. You'll need to read labels carefully or check with manufacturers to be sure.
Do I need to check every single product?
Initially, yes. It might seem overwhelming, but becoming familiar with gluten-free labels and certifications can help. You should also consult with a dietitian who specializes in gluten-free diets.
Thank you, doctor. This gives me a clear starting point to manage my diet better.
Now look at question 26.
Good morning, everyone. Today I'll present on the advancements in the management of chronic kidney disease, particularly focusing on new therapeutic approaches. Our team has been part of a multi-center study evaluating the effectiveness of newer pharmacological agents like SGLT2 inhibitors. These have shown not only to help control blood sugar levels in diabetic patients, but also to offer protective benefits for kidney function. Alongside pharmacology, we're also emphasizing the critical role of dietary management and regular exercise. I'll discuss how these components integrate into our overall treatment strategy and how we can better communicate these options to our patients for improved compliance and outcomes. By the end of this session, I hope to propose a comprehensive management plan that includes these advancements.
Now look at question 27.
I see that you're quite upset. Let's talk about what's bothering you so we can address it together.
Every time I come here, I wait for hours just to get a shot of pain relief. It's not enough. I'm still in constant discomfort.
I'm really sorry to hear that you're in pain and that the wait times have added to your frustration. Pain management is a priority, and it sounds like we need to reassess your current plan.
I just feel like nobody's listening. What's the point if nothing changes?
I'm here to listen, and I assure you, your concerns are important. Let's schedule a meeting with your doctor to discuss more sustainable and effective pain management options. We can explore different medications or alternative therapies that might work better for you.
I appreciate that. I just want some relief and to feel like my time and pain are taken seriously.
Absolutely, and you deserve that. Let's make sure we follow up on this promptly. Your comfort and health are our utmost priority.
Now look at question 28.
Welcome, everyone. Today, I am excited to discuss enhancing participant recruitment for our clinical trials, which is vital for the advancement of medical science. I'll cover several key strategies, including digital outreach through social media platforms, collaboration with patient advocacy groups, and leveraging electronic health records to identify potential candidates more efficiently. Additionally, we'll explore how to communicate effectively with potential participants, emphasizing informed consent and addressing common concerns and misconceptions about trial participation. By improving our recruitment strategies, we can ensure robust study results and contribute to better health outcomes for all. Our goal is to create a more participant-friendly approach that respects and values the contribution of each participant.
Now look at question 29.
We've noticed fluctuations in your oxygen saturation levels during your last few visits. Let's discuss what this means and how we can manage it.
I've been feeling more short of breath lately. Could this be related to my oxygen levels?
Yes, it's likely connected. Oxygen saturation is a measure of how much oxygen your blood is carrying compared to its full capacity. Ideally, it should be between 95 to 100%. Levels below this range can cause symptoms like breathlessness.
What can we do to improve my oxygen levels?
Treatment options vary based on the underlying cause. It might involve supplemental oxygen, medications, or pulmonary therapies. We also need to monitor your levels more regularly to adjust treatments as needed.
I'm willing to try anything that might help. How soon can we start?
We can start as soon as we have a detailed plan from your pulmonary specialist. I'll arrange a referral right away. In the meantime, let's monitor your symptoms closely and adjust your activities to help manage your breathing.
Now look at question 30.
Today, we delve into the challenges and management strategies associated with comorbidities in hospitalized patients. This is a critical area of concern as patients with multiple health issues require complex care strategies that can impact both outcomes and resource allocation. I'll present data on the prevalence of common comorbidities such as diabetes, heart disease, and chronic lung conditions, and discuss how these influence treatment plans and patient care. We'll explore interdisciplinary approaches to care, the use of technology in managing health data, and the importance of patient-centered communication. By understanding and addressing the complexities associated with comorbid conditions, we can improve care coordination, enhance patient satisfaction, and ultimately achieve better health outcomes for our patients. Let's discuss actionable strategies that we can implement in our practices to handle these challenges more effectively.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Hello everyone, and welcome to today's webinar on the management of bleeding disorders with a particular focus on acquired conditions like immune thrombocytopenia, ITP, and acquired hemophilia. I am a consultant hematologist, and I'm delighted to delve into these challenging and complex topics with you today. Our discussion will include a detailed case study to highlight practical management approaches and the latest advancements in treatment protocols. First, let's discuss immune thrombocytopenia, or ITP. ITP is an autoimmune disorder characterized by isolated low platelet counts, often without a clear cause, leading to increased bleeding and bruising risks. Management of ITP primarily revolves around the suppression of the immune system to halt the destruction of platelets. Treatments often begin with corticosteroids, and depending on the patient's response, may include IV immunoglobulin or splenectomy in refractory cases. A landmark study published in Blood, the Journal of the American Society of Hematology, demonstrated the efficacy of rituximab as a second-line therapy. This study highlighted a significant improvement in platelet counts and bleeding symptoms in patients who did not respond adequately to first-line therapies. Let's consider a case study that reflects this scenario. We had a patient, a 45-year-old female, who presented with petechia and mucosal bleeding. Initial platelet count was alarmingly low at 10,000 per micromelis. She was immediately started on high-dose prednisone, but her response was suboptimal. Her platelet count increased marginally and remained under 30,000 per ml, which was far from the safe threshold. Given her persistent risk of serious bleeding, we initiated treatment with rituximab. Over the next 4 weeks, her platelet counts improved steadily, reaching a safer level of over 100,000 per ml. This case exemplifies the need for hematologists to be agile in escalating treatment based on the patient's response to standard therapies. Now, turning our attention to acquired hemophilia, this is a rare but life-threatening condition caused by autoantibodies against clotting factors, most commonly factor VIII. Patients present with sudden, severe bleeding and often a prolonged activated partial thromboplastin time, APTT, with no prior history of a bleeding disorder. Published in the New England Journal of Medicine, a review of this condition recommends the dual approach of controlling bleeding through bypassing agents such as recombinant factor VIIa or activated prothrombin complex concentrate, and eradicating the inhibitor using immunosuppressive therapies, including corticosteroids, cyclophosphamide, or rituximab. Let's consider another case that illustrates the acute management of this condition. A 68-year-old male presented with extensive muscle hematomas and an unexplained APTT prolongation. He was diagnosed with acquired hemophilia after factor VIII levels were found to be less than 1%. His initial management involved recombinant factor VIIa, which controlled the acute bleeding episode. Concurrently, he was started on high-dose prednisone and cyclophosphamide to suppress the inhibitor. Over several months, his factor VIII inhibitor decreased and his APTT normalized, demonstrating a successful eradication of the inhibitor. These cases underline the complexity of managing bleeding disorders, particularly when they are acquired rather than inherited. The rapidly evolving landscape of therapeutic options requires hematologists to stay updated with the latest evidence and treatment modalities. The management of bleeding disorders is multifaceted and depends heavily on the type of disorder, whether inherited or acquired, and the severity of the patient's symptoms. It's critical to personalize treatment plans and consider all available therapeutic options, including emerging treatments. I hope this discussion provides a comprehensive understanding of the complexities involved in diagnosing and managing ITP and acquired hemophilia, and underscores the importance of staying current with ongoing research and clinical trials in the field. Thank you for joining today's webinar, and I look forward to your questions.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Good morning, everyone, and welcome to today's clinical conversation on the complexities of epilepsy management, a topic that, while common in clinical practice, requires a nuanced understanding for effective management. Today, we will delve into the intricacies of diagnosis, treatment, and patient management through a detailed case study that illustrates the challenges and considerations in treating epilepsy. Let's begin with our case study. We have a 28-year-old male, John, who presented to the emergency department with his first known seizure. John was found by his roommate during an episode characterized by generalized tonic-clonic activity. The event lasted approximately 2 minutes, and upon regaining consciousness, John was confused and disoriented, a state that lasted for about 30 minutes post-event. His medical history was unremarkable, and there was no family history of seizures or epilepsy. The initial approach in a case like John's involves a thorough assessment to determine the cause of the seizure. A detailed medical history is crucial, as it helps us exclude potential provoking factors like alcohol withdrawal or electrolyte imbalances. In John's case, both were ruled out through history and initial lab tests. The next step, naturally, involves neuroimaging. An MRI of the brain was performed to rule out structural causes such as tumors, strokes, or any abnormalities that could trigger seizures. Concurrently, an EEG was scheduled to assess any underlying epileptic activity. In John's EEG, we noted spikes and sharp waves indicative of epileptiform discharges in the left temporal lobe, suggesting a focal onset, which could be amenable to anti-seizure medications. This finding steered our diagnosis towards epilepsy, potentially focal epilepsy, given the EEG findings and the clinical presentation. Now, treatment initiation is a critical decision point in epilepsy management. According to current guidelines, including those referenced from Harvard Medical School, the decision to start treatment after a first seizure is influenced by the risk of recurrence. Factors that increase this risk include an abnormal EEG, as seen in John's case, a significant brain imaging abnormality, or a nocturnal seizure. Given these factors, and after a detailed discussion with John about the potential risks and benefits, we decided to initiate treatment with levetiracetam. This medication was chosen for its efficacy in treating focal seizures and its relatively favorable side effect profile compared to older medications. Now, managing epilepsy is not just about prescribing medication. We need to consider the broader impacts of this diagnosis on John's life. For instance, counseling about lifestyle adjustments is crucial. Issues like sleep deprivation and alcohol consumption can lower the seizure threshold and need to be addressed actively in patient education. Furthermore, we discussed the psychosocial impact. Receiving a diagnosis of epilepsy can be distressing and may affect mental health. Referral to a counselor or support group was recommended to help John cope with this new diagnosis. Epilepsy can also impact an individual's ability to drive, work in certain jobs, or partake in various activities, which necessitates discussions about local laws and safety regulations, like those from the DVLA in the UK, which regulate driving for individuals diagnosed with epilepsy. The management of epilepsy is multifaceted and extends beyond medical treatment to include patient education, lifestyle modification, and psychosocial support. Ongoing evaluation and adjustment of the treatment plan are essential, based on the patient's response and any side effects of the medication. Epilepsy, as seen through John's case, exemplifies the need for a comprehensive approach to diagnosis and management. Each patient's treatment and counseling must be tailored to their specific condition and life circumstances. This approach not only helps in managing the condition more effectively, but also supports the patients in maintaining their quality of life. Thank you for your attention today. I hope this session provides a deeper insight into the thoughtful management of epilepsy, ensuring that we offer the best care to our patients while navigating the complexities of this neurological condition.